A very good afternoon to all those who are viewing the YouTube channel of Association of Surgeons of India. I'm singularly blessed to address you in the first ever joint meeting, the webinar jointly conducted by the Royal College of Physicians and Surgeons of Glasgow and Association of Surgeons of India. On behalf of both the organizations, let me take this opportunity to welcome the members of both the organizations viewing this program in the YouTube channel of ASI. We have this historic moment for the first time, the webinar series happening between these two organizations, and to grace this occasion, we are blessed to have the presidents of both these organizations. May I now request Professor Mike McCurdy, the president of the Royal College of Physicians and Surgeons of Glasgow, to address the gathering. Professor Mike.
Thank you very much indeed, Santosh. And can I firstly say what an immense pleasure this is. What an exciting moment for the Royal College of Physicians and Surgeons of Glasgow and the Association of Surgeons of India to be running this joint webinar. My name is Mike McCurdy. I have the great privilege of being the president here of the Royal College of Physicians and Surgeons of Glasgow. I'm speaking to you from our college building in the centre of Glasgow, which I know many of you will have visited in the past. And I made my first overseas visit as president of the college to India in July. And it was a great pleasure to meet so many colleagues and friends from the Association of Surgeons of India at that time. As surgeons, we want the very best quality of care for our patients. And for us to achieve that, we need to be knowledgeable and skillful, but we also need to be willing to learn and to admit when we don't know something so well and to learn from other people. So we're very fortunate today to have two excellent expert speakers, one from here in Glasgow and one from colleagues in India. And I really look forward to this afternoon's meeting. This is a wonderful start to this using modern technology to collaborate between the Associations of Surgeons of India and the Royal College of Physicians and Surgeons of Glasgow. So I hope all goes well. So far, the technology is holding up. Let's have a great afternoon.
Thank you, Professor Mike, for those kind words. Now I request President, Association of Surgeons of India, Professor Sanjay Kumar Jain, to address the gathering. Professor Sanjay.
Thank you, Dr. Santosh. Good evening to all my friends in India, and good afternoon to all the guests in UK. I welcome you all on behalf of the Association of Surgeons of India to the opening program of the webinar series between the Royal College of Physicians and Surgeons of Glasgow and the ASI. I welcome the President of Royal College, Professor Mike McCurdy, the two Vice Presidents. We are happy to have them with us, the John Camille Brennan and John Scott. The two Johns are here. We are awaiting the presence of our registrar, Dr. Abhay, and the member of the academic team, Jennifer, is with us. And a very distinguished speaker from the Royal College side, Professor Graham McKay, and our India counterpart, Dr. Kushal Mittal. We planned this webinar series with the topic of interest of the majority of the general surgeons across the country and to the benefit of very many patients who suffer these problems, which even they shy to speak about with even best of their friends. And I hope that this series is going to be of immense help. We will be coming up quarterly with these presentations to you, and the first two are on the colorectal problems, and next two will be on the benign breast diseases. I thank all of you for an overwhelming response when the registration has gone over 2,400 marks. I hope this is a first of its kind for any webinar after COVID pandemic. So I hope you will enjoy today's program. Thank you everyone for joining us, and over to Dr. Santosh to take the proceedings.
Thank you, Professor Sanjay Jain. We have the gracious presence of two vice presidents of the Royal College of Physicians and Surgeons of Glasgow, may I have the pleasure to invite Mr. John Camilleri Brennan for the first address, followed by Dr. John Scope. Mr. John Brennan, please. Please unmute, sir. Please unmute. Please unmute, sir.
Can you hear me?
Yes, perfect.
Good evening, President. Good evening, distinguished guests. I'm very pleased to address your webinar, which we have jointly organized, our college, Royal College of Physicians and Surgeons of Glasgow, and your association. I was pleased to be involved in the initial discussions and in the organization, and may this bring and reap the rewards that we have been expecting from these types of collaborative webinars. The first two webinars will be on colorectal topics, common colorectal topics that affect the quality of life of patients worldwide. And the other two webinars will be on breast diseases, also common conditions. So I'm sure that these webinars will be very successful and will bring us closer together as a surgical community. Thank you.
Thank you, Mr. John Brennan. May I have the pleasure to invite Mr. John Scott, Vice President, Royal College of Physicians and Surgeons in Glasgow, to address the dialogue. Dr. John.
Good evening. It's a tremendous pleasure to meet you all over the internet, and thank you for President Jane's warm welcome. Immensely excited about this forthcoming series of webinars, which truly show an international relationship that I think is going to prosper from going forth, and we've got lots to learn from one another. So immensely interested in the forthcoming webinar and the ones on later in the year on breast surgery. So thank you, and hope you'll enjoy this evening's presentations.
Thank you very much. We had expected to have Dr. Professor Abhay Rani, the registrar, and we also have expected Dr. Raghuram and Dr. Prabol Niyogi to join us. They are unavoidably absent, so we will straight away go to the proceedings. Professor Graham Mackay is the first presenter. If he is ready, we will have Professor Graham to talk on. If not, we will take Dr. Kushal. Professor Graham, are you okay to take on the first lecture? I think he's going to take a little while. So I would request Dr. Kushal Mittal to have his talk on the fistula in Nano. I would have the pleasure of this. Kushal, just give me a time.
Yes, sir.
Dr. Kushal, can you give me a...
I can hear you. I can hear you, Dr. Santosh. Hello.
Hello. There is some
Can you
overlap, I suppose.
Can you hear me? Dr. Jain, can you hear me?
Yes, sir. We can hear you.
Okay. Okay.
There is an overlap. Abneet.
Yes, sir.
Can you just stop that YouTube with you?
No, there's
The
no
sound
YouTube
of the
with me,
YouTube.
sir. There is no YouTube with me, sir.
No, it is overlapping. Okay, anyway, Dr. Kushal, can you just share your slides and talk?
Yes.
Santosh sir, would you like to introduce the two speakers? If you
there is something.
Can you see my slide?
Yes, yes.
When you tell me, I'll start.
Hello, Kushal, can you hear me?
Yes, sir. I can hear
Okay.
you.
So you're ready to talk. I would like to introduce Dr. Kushal to all of you. He is a very leading anorectal surgeon in the country. He is the incoming president of the Association of Colorectal Surgeons of India. His CV runs into pages. He has authored many books. He has been an invited faculty to various international meetings of colorectal surgical associations, and he is a lead faculty, operating faculty in many of the local, state level, national level, and international level conferences. So I have immense pleasure in requesting Dr. Kushal Mittal to deliver his lecture. Dr. Kushal, please.
Thank you, sir. It's a pleasure to be and an honor to be called. I thank Dr. Sanjay Jain, ASI President. I thank Dr. Prabal Yogi, incoming ASI President, and Dr. Santosh Abraham, who has actually designed all this academic work. And a pleasure to meet Professor Mike McCurdy and all the people from UK and India. I'm going to be speaking on a topic which is of utmost importance in India. That is management of perianal sepsis or fistula. The topics I want to cover is the anatomy of the anal canal, geography of the spaces, the anal gland infection and spread, anal abscess and their management, fistula classification and principles of management, what is sphincter cutting and what is sphincter saving surgery, and post-op fistula wound management. The surgical anatomy of fistula. For a successful fistula surgery, we need intimate knowledge of the architecture of the sphincter muscles, which I will cover, the distribution of the anal glands, and the geography of the anal spaces. Then only we can really succeed. And you have the anatomy of the anal glands. You have various facial sheets. You can see on the screen, you can see the various septum, issue-rectal septum, transverse Milligan septum, and the anal glands coming here from the dentate line. And then you have the anorectal ring, which is comprised by puborectalis, deep external anal sphincter, and internal anal sphincter. Just a second. Yes. Now, when I talk about how to operate, we must always keep in mind the external anal sphincter, which comprises of subcutaneous, superficial, and deep fibers, and the puborectalis and the levators. And when we talk about facial planes, we need to know these planes. We actually don't know them. That what we know is the Milligan-Morgan septum. Then you have the facial lunata going up like that. Then you have the inferior diaphragmatic pelvic diaphragm fascia. And what we always think about is when you have a transpintric abscess, it comes through this space and comes down here, but we don't realize that it can come here and go up and become infralevator, not actually even extending to the buttocks. And these patients come late because you don't feel anything on the skin. So this is an abscess traveling from low transpintric abscess, and this is a high transpintric abscess. And this is infralevator abscess. And all of them have different treatment. I'm showing you these muscles because the sphincters to spare are the external, this portion in green, that is half of superficial external anal sphincter, and the puborectalis sling and the levator ani needs to be safeguarded whenever you're performing a sphincter cutting procedure. This area is of utmost importance, and we need to always see that nothing happens to it. Now, the potential spaces in the inoderm are numerous, and it's listed on the left side. The one in bold are the ones we don't know about and we miss. That is superficial postanal, deep postanal, and retrorectal. And because we miss this, the patient have recurrences, and we need to take care of that in the first surgery. The geography of the anal rectal spaces is spread out on both the sides. The thing we need to understand, it's like two tubes, two circles, and there's nothing to divide the circles. So if abscess starts at one point, it can go all the way around the sphincter, and that's why we have a problem. And what we need to know is, apart from the spaces you see on the left side, from here, you have submucosal, intersphincteric, perianal, ischorectal, and supralevator. These ones we know. This one we ignore, that is the deep postanal abscess and the extension upward retrorectal abscess. And these are the ones which recur and cause patient morbidity. The anatomy of the anal glands is of utmost importance. You need to know the glands are at the dentate line, starting at the crypts, and they go downwards. Most of them go downward. That's why we have intersphincteric and perianal most of the time. But some of them go up, and that's why we have the high transsphincteric ones. We need to know these are upper-groin glands, and 3 to 12, mostly posterior. The ducts open in the crypts at the dentate line, and multiple glands open in a single gland. So what actually happens to these glands? They become obstructed, stasis, infection forms, abscess forms, tuberculosis spreads by the lymphoid follicles which are present in that area. And we must keep in mind that anal fistula is 90% cryptoglandular infection. If we keep this in mind, and we know it's at the dentate line, we can actually manage properly. Now, what actually happens when the gland gets infected? It's in the intersphincteric region. You have an abscess pus coming here in the intersphincteric. And as the pressure is applied, the patient sits, stands, this goes upwards. It may go high intersphincteric, it may go supralevator, it may go transsphincteric, it will go perianal, and it may go submucosal also. So extension is in all the directions. And abscess formation results. This is the submucosal. Then you have the intersphincteric. Then you have the perianal. Here you have the low transsphincteric abscess. Then you have the high supralevator abscess and the high transsphincteric abscess. Now, the low and the high transsphincteric abscess have different treatment. Whereas the low one, you can just do a primary fistulotomy. And with the high one, you need to go in for another procedure. Now, looking into this pelvic diaphragm from the sides in a 3D dimension, why are these spaces important? It's funnel-like, it's tube in tube, and follows septal planes. Now, this is the intersphincteric space where the abscess develops. Then you have the extrasphincteric space where the abscess develops. And then you have the suprasphincteric. And as you see, it can go all around. That's why the horseshoe is so common. And we keep wondering how it went. There's nothing to stop the pus from going from one end to the other end. Now, when we are talking about abscesses, you need to know how they actually spread vertically. If you know how they spread vertically, you know how high to go. So, but keep in mind, even though they're spreading vertically, you have to keep in mind that they start here at the dentate line. And that's the beauty of it. You have to address this area, and the rest will take care of itself. Then horizontal spread. It goes in a circle. It goes all around, just as I told you. So you can have horseshoe, subcutaneous, intersphincteric, transsphincteric, and suprasphincteric. And posterior horseshoe is more common than anterior horseshoe. And because the abscess is going all around, therefore, it's more difficult for the surgeons to treat because they are treating only one side. The other side may not be apparent. And because they haven't got the patient investigated, because they didn't get an MRI done, they don't know it exists on the other side. And therefore, the patient comes back after a few weeks with abscess on the other side. Now, the route of facial spread is really important because it tells you what's going on and where it's going on from. And this is going up in the back. This is high intersphincteric, can go up all the way. Patients coming with abscesses on the chest wall, and the origin is the anal gland. And then you have, it can go crossover from behind and go suprapubic and open in the abdominal wall. And it can go and open at the base of the penis or in the scrotum. And these are pictures of patients who were explored. Exploratory laparotomy was done for pelvic abscess, but there was nothing inside. And this abscess does not penetrate the peritoneum. So you need not look inside the peritoneal cavity. You need to look at the anus, and then you have to drain these cavities. The picture below shows an extension of a transsphincteric abscess into the leg. It can go up to the knee. That's the lowest part I've seen is the pulpiteal fossa. So it can go up to the knee, and you need to know because these abscesses in the anus region, you don't see anything, but the orthopedic surgeon gets this patient, they operate, and the patient has a recurrence. And when they send for MRI, that's when they find out, okay, there's some other problem. The spaces we miss posteriorly is the deep superficial postanal space and the deep postanal space, and we need to take care of it. The deep postanal space can easily be taken care of by going through the superficial postanal space. You have the anal coccygeal ligament. You divide it vertically and not horizontally, and you can drain the pus, and it needs to be done. Then we miss retrorectal space. Then we miss the deep intersphincteric space posteriorly. Anteriorly is the internal anal sphincter. Posteriorly, laterally is the external anal sphincter, and it is inferior to the puborectalis muscle. We miss it. And anteriorly, we miss the anterior deep space, the spread of abscess to the deep anterior space, and this is causing a lot of problem in females. Now, the conjoint longitudinal muscle is an interesting muscle. Actually, you don't see it on the table, but it's labeled, and what it does is, it's like a septum. The abscess which is penetrating it will form a supralevator abscess. The abscess which does not penetrate it goes between the internal anal sphincter and the conjoint tendon, and it goes to form a high intersphincteric abscess. And the treatment of both is different. So clinically, you need to know the history examination, internal opening, external opening, tract and sphincter status. And you also need to know the continence status of the patient, whether the patient is normal, incontinent, and what is the degree of incontinence. You have to document it so that post-op, if the patient has a problem, you can always have a documentation. He already had it beforehand. This is Wechner's scale, and it's a very good for evaluation. Radiologically, endoanal and perianal ultrasound are there, but it is highly operator dependent, and it doesn't really help when there's a recurrence. And if the fistulas are high tracts, it has difficulty in finding it. I personally feel that MRI is great. It tells you all the tract in relation to the external anal sphincter. And because you know the relation with the external sphincter, you know, okay, this is crossing at this point. It identifies the internal opening and the spread, defines the sphincter morphology, high sensitivity and specificity, and reduces the recurrence by 75% is a gold standard. Now we get an MRI done, and do we get MRIs in anal abscess? Yes, definitely. Unless it's a perianal abscess, it's a very small abscess. You can see it, you know it's only perianal. But for all other non-cryptogynous abscess, persistent post-drainage, supraelevator, multiple spaces, horseshoe, occult abscesses where pain sepsis is there, but you can't see anything and you are unable to examine the patient. This is an intersphincteric abscess in auto rickshaw driver. He didn't let me examine him, and you can see the amount of pus in the intersphincteric space. And because both the muscles were being pushed out, he had severe pain. Now, what we get done is we don't want the films. The films really don't help a surgeon. At least in India, it doesn't really help the surgeon. What we want is a diagram. So we tell them then to make a diagram like this. So they've got the diagrams here. And then we ask to make a glamour film. This is called a glamour film. That means the best 8 pictures or 6 pictures of all the MRI histogram, they are labeled, and then you get it with you. So this is the labeling. So this is the MRI picture. It's labeled line diagram, and they make it like this, and they show it here. And all this in yellow is being the label, and this is called the glamour film. Dr. Ravi Thapar in Mumbai does a fantastic job. And fistulogram, you can see, and then you have the diagram. And with the diagram, you know where the external sphincter is involved, where the internal sphincter is involved, at which level it's going to be cutting. And that's the glamour film. And you see the film. See this film here, and see this. And here is written coccygeal osteomyelitis. This patient had tuberculosis, and he had the involvement of the coccygeal bone. Now, once you've got all this information down, you make a roadmap. You mark the abscess in the fistula. So in this chart, you have to fill it in. You got the diagrams in the center. You see the inner tone, primary tract, secondary tract, internal opening, external opening. On the right side, you see, is it horseshoe? Is it an abscess? What is the Wechner incontinence score before MRI endoscopic finding? Then on table examination under anesthesia, intraoperative finding. What did you do and what are the results? And Wechner score 1 month post-op. So you have a complete workup of fistula. So before surgery, if you can get all this information, except the one in the OT, you connect all the dots, and then you plan what to do. So you have an abscess, and these abscesses will ultimately drain and become fistula. Now, one thing you need to note is people frequently see abscesses don't have a fistula tract. No abscess can exist without a fistula tract. And if we can find that fistula tract and manage the fistula tract, then this patient will not develop a fistula later on. See here, you have the MRI and you shows the abscess, and this shows the fistula tract. The first rule is do no harm. Now, when the saying events on the table and you press on the abscess, nothing comes out. So what you do is put the needle in middlemost part and inject 1 cc of methylene blue with a few drops of hydrogen peroxide. It comes through the internal opening. You know what it is. You can do a primary fistulotomy. Rates of recurrent disease, 2.8% primary fistulotomy, 40% in which incision drainage was done alone. Now, if you are going to probe an abscess or even a fistula, you need to know the internal opening is going to be at the dentate line. Yet our finger is always on the anorectal ring. Why do we keep our finger so high up? What's going to happen here? The probe is going to go in the wrong direction, and you see iatrogenic fistula. This patient had an abscess, and then you see the original line is here. Then these two are the probings, and this is going to cause a lot of nightmare to the patient. So, what we were doing till now: cruciate incision and drainage, large incision, incision over the most prominent part, finger fracture of the loculi, abscess cavity packing, and everything has changed. It's a stab incision, 5 to 10 millimeters, incision close to the anus, no finger fracture, only curate, no two abscess cavity packing. I stopped making roller gauges for packing abscess cavity about 15 years back. So, how do we approach an abscess? Principles of abscess drainage lie in the fact that you have to see whether the internal opening is there or not. If the internal opening is there, you do a primary fistulotomy or you put a ceton in. If the internal opening is not found, you put in a tube or put a Foley's or a Mallicots. Minimally invasive surgery is vast. It's very good. I do all abscesses, almost all abscesses except the perineal one, by minimally invasive surgery. And horseshoe abscess, you can do a modified Henle's or whatever way you want to modify it. So there is a rule we got to follow, and we don't follow. The rule is the external anal sphincter. The external anal sphincter, any abscess which is medial to the external anal sphincter, which could be supralevator from below, supralevator from above, intersphincteric or submucosal, they have to be drained inside. And if the abscess is crossing the external anal sphincter, then they have to be drained outside. No to cruciate incision. These are awful. They don't heal because the primary tract is still there. These are going to have recurrences. There's no point 3 months of dressing and regularly packing and causes a lot of misery to the patient. So we should stop making large incisions like this. Look at these patients. All of them had large incisions, 6 to 8 centimeters long. Did it help them? No, they have a recurrence. And the recurrence on the first picture is on the other side. Here, young unmarried girl on the same side. And this patient from scrotum to this place, 8-inch long incision, recurrence again. There is no point giving large incisions. Secondly, we have to say to no to finger fracture. We are damaging the internal pudendal vessels, dorsal nervi or penis, perineal nerves, pudendal nerve, and internal pudendal artery. They are ruptured. So when you put your fingers in and you say, you know, I've broken all the loculi, you're not breaking them, you're actually breaking everything else. And that's why there is such bleeding inside. If you're just going to put a curate in, bleeding is not going to be there. So don't have enough opening that your finger can go in. Finger should be absolutely banned from putting inside. And do not pack it. Don't need to pack it. Just put a drain inside. So what is your incision line? Look at these. I'm going to be talking about them. In your mind, decide what would you do if you had a patient like this. So primary fistulotomy for ischiorectal abscess is first. I'm going to talking about this. So what do? We make an incision here for perineal abscess, and then for ischiorectal abscess, make it to the medialmost part of the abscess. For submucosal abscess or intersphincteric abscess, you cut down from the base all the way outside the inner walls. You can do a dressing afterwards. And for supralevator abscess, you can cut down from top to bottom. The best way to drain these abscesses. And you can cut it, and this is how you're cutting it, and that push. One of the things we are always terrified about is cutting the internal anal sphincter. You can cut it to about just below the anorectal ring, like 0.5 centimeter below the anorectal ring. To that point, you can cut the internal anal sphincter without any problem. How much of external sphincter? Subcutaneous and part of superficial. Now, internal opening seen in the ischiorectal abscess, and you've seen this internal opening. That's the internal opening, and this is the fistulotomy. You're going to do a primary fistulotomy, and If there's no internal opening, drain and tube, internal opening, then you have option of primary fistulotomy and a C10. This is just drainage, and this is primary fistulotomy, and then you have a C10 placement. Now, when do you place a C10 and when do you do a primary fistulotomy? When the amount of muscle which you are going to leave behind is less, then you put a C10. Is more, you do a primary fistulotomy. Make it the other way around. If you're cutting too much muscle, if you think too much muscle is going to be cut, put a C10, otherwise do a primary fistulotomy. So primary fistulotomy in an abscess, this is an abscess at 7 o'clock. Just by pressing it, you will see pus coming out. And when you put your instrument in, the pus is coming out from an opening somewhere around 7 o'clock. I do all abscesses by scope, I said. This is WAF, just clean everything out. After cleaning it, make sure there's nothing else and just take a cautery and cut down that muscle and make sure there's hemostasis, and that's all you need. And post-op, because you've gone outside the anal void, you can irrigate them. Now you have ischiorectal abscesses like this. You can make small incision and drain them. Or you can do a primary fistulotomy. We already told you that, and the abscess is drained. So what next? So you can put a C10 if you think too much muscle is there, or you can put a drain in. Now, the left is a young girl who's been operated 3 months before she came to me, and when I did it, too much muscle was there. So I didn't want to do fistulotomy anteriorly, big fistulotomy. So I put in a C10, and that's all you need to do. I looked in with the WAF scope, saw everything, and then put C10 in. WAF scope just tells you what it gives you information. You can clean it out, and that's about it. You don't have it, you can still do it without the WAF scope. And the one on the other side is a male who had an intersphincteric abscess, which is spreading out from the intersphincteric space, coming out all the way. And you need to give in hydrogen peroxide and make an incision on the intersphincteric groove, and that will drain the whole abscess. And you can even cut down to the internal opening, you'll find it. Then large abscess, you can keep a Foley's in. Now, this patient had a very large abscess here, and also an internal opening which could be seen. A lot of muscle was involved. Infiltrating tube was kept as a C10, and a thick Foley's catheter 3-way was kept, and the patient has done well. So, clinical practice guideline says abscess drainage with concomitant fistulotomy in selected patient with simple anal abscesses, grade 2B. Now, what do we do when you want to do a sphincter repair? This is excising the internal opening. Then you're excising everything else. You're doing fistulotomy. You're closing the external anal sphincter with 20 PDS, and you're closing the internal anal sphincter with 30 Vicryl, or you can leave it open. So I'm showing you 2 films. This was given to me by my colleague, Dr. Kamal Gupta, where primary fistulotomy was done and primary sphincter repair was done. After cleaning everything out, you see the abscess on the right side. Now, one of the tricks of doing all these surgeries is take out the internal opening, take out the central lesions, the internal opening, the internal sphincter up to the intersphincteric space. After doing that, you can cut the tract. Now, fistulotomy is being done. At this point, if the muscle is being cut, everything is going to be curated, cleaned out. And similarly, on the other side, and since the abscess was extended to the base of the scrotum, so an infiltrating tube was kept in, and everything cleaned out. After you have done this, then you repair the sphincter muscle, external anal sphincter with PDS 20, and you can repair the internal anal sphincter with Vicryl. And the other side, you're muscularizing it, you're doing a fistulotomy and just muscularizing it. So intersphincteric abscess, we know it's all in the books, nothing new about it. You just drain it, and the problem which is there is the deep post-anal abscess. You have to drain from below. The patient has to be prone, and the markings, I'm showing you the 2 markings. And when you do a ischiorectal abscess, you see all 3. They have the same procedure being done. Basically, you got to drain them, and you got to put in a catheter. The catheter can go inside the anal canal, or it can go outside the anal canal. Picture number 1 is going to go outside. Picture number 2, left bottom, is going to go inside. And the left one, this picture here, the reason that the patient came to me was he was told to get a colostomy done first, and then your fistula surgery will be done, and he didn't want a colostomy. And colostomy is unthinkable. We don't even think about doing a colostomy. And you put a scope through all of them, and you can see the lower part of sigmoid, and you can see the anal canal, and you can see for any other pathologies are associated. And waft is a really good way to help you. Coming to fistula, first thing you have to do is locate the internal opening. You know, I know that 90% of the openings are at 6 o'clock at the dentate line, and this is where it's going to be. When you see the internal opening, you can examine under anesthesia, you see puckering, you can probe, inject saline surrounding the area where the internal opening is there. Is not going to get elevated. You can put in methylene blue, and you can do pouring and pulling on it. 6 P's: pit, pulse, papilla, puckering, probing, and passage of dye. So this is dye being passed from outside, and it didn't help. So the probe can be passed from inside. So on passing the probe from inside, you know where it is. And here again, the same thing. Now you can probe, you just have the internal opening, you can probe that, you can press on it and you see the pus coming out. Or you can dissect the external opening and pull, you can see the tug at the anal canal. So endoscopically, you can locate it, the light shows you, it comes up to the internal anal sphincter, and you know, okay, this is where the tract is going to open. The dentate line is important because anything you cut above the dentate line, the primary sphincter repair has to be done. The reason I'm showing you this diagram is, see all the vessels behind it. This is a very vascular area, and you need to operate from inside. And when you're doing it, you need to be careful. You need to inject saline adrenaline, wait for 5 minutes, and dissect. Use Scotty in the right settings. Don't cut too much, but cut enough to take the disease out. So in females, anteriorly, don't cut any muscles, posteriorly 30%. In males, anteriorly 30%, and posteriorly 50% of the external anal sphincter can be done. Now remember, locating the primary, if you have external opening in the base of the scrotum, it may not open at 12 o'clock like we think. It can open up at 6 o'clock also. So how much can you cut? This is the diagram. You see the external anal sphincter, you see the conjoint longitudinal muscle, and then you have the levator, deep external anal sphincter, superficial external anal sphincter, and subcutaneous. So you can cut up to dentate line. They'll be at the most flattest incontinence. So don't worry about it. Anorectal ring, if you cut that, you have complete incontinence. You need to know the triple loop system of Shafiq says that one of the loops have to be intact, and preferably the one to be intact should be anorectal ring. Now, the height of the tract in relation to external anal sphincter. 2 centimeters from anal verge, dentate line, that's where you have your cutoff. You don't go above this. And if you go 2 centimeters above that, you have the anorectal ring, and do not do it. When you're dissecting, you have to remember one thing. For the first 2 centimeters, fistulectomy can be done. For the portion above, fistulectomy, if you do it, do a primary sphincter repair, or you can do waft and laser. Fistula classification, we're aware of it, 3 types: Sparks, American Society, and the radiological St. James, what we get on the MRI reports. Now, this one, I want you to really see 70%, new says 70% of all the fistulas are intersphincteric. And I've already told you, you can sacrifice the internal anal sphincter. So if you can sacrifice the internal anal sphincter, why do we have such a difficult problem in tackling majority of the fistulas which are intersphincteric? The external sphincter is intact. And that's what we are always worried about. It's the internal sphincter. So you need to put a probe in, and you have to cut over the probe up to the height, and the portion you can go up to, well and good. If you can't go up, you can curate it. Now, if you become an expert, don't cut it over the probe. Cut around the internal anal opening and follow that whole tract as far as possible, and then curate the rest, and you can close the internal opening if you do it. Type 2 is about 20 to 25%, that is transsphincteric. Suprasphincteric is type 3, which is about 1 to 3%, and external is 1 to 2%. So we are always saying patient has a high fistula NO. When we say high fistula NO, what does that mean? Does the patient have a high internal opening, or the patient has a tract which is going up and coming down? So these tracts are going up and coming down, but ultimately they open up into the internal anal sphincter. The choices in a complex fistula, traditional procedure, fistulotomy, fistulectomy, primary sphincter repair, CETA, and advanced clamps. Less recurrence, but higher incontinence. Would you want it? Then you have the sphincter saving, where you have lift, waft, laser. You have the plug, I'm against it, glue, and India does not support plug, glue, and stem cells. It costs a lot of money, and the failure rates are very high. There's no point doing it. There's a higher recurrence, which is tolerable, with minimal incontinence, which is wanted. So you have to balance. If you were the patient, would you want incontinence or recurrence? And I'm sure everybody would be happy with the recurrence than an incontinence. So the choice of surgery for an intersphincteric fistula, depends on what type of fistula there is, and the selection procedures aim to cure the challenge we face, preserving the sphincter and incontinence, and choices we have to make. The first surgeon is the best surgeon. Now, let's see with the fistula. So you have the intersphincteric fistula. This is type 1, and all of this is going up. All you need to do is you have to start the dissection from here, from inside, and you go down, you do a primary fistulotomy here. You can do a primary fistulotomy and curate the rest, or you can even follow this up and cut it out. And you have this third category where waft would be really good because you don't have an internal opening, and then you have this. And then you have the abscess. So the treatment for all of them is essentially the same. You cut out the internal opening here, you cut this whole thing out. For the ones which are coming down, do a primary fistulotomy. The rest you can cut this out and you can just follow it up as much as possible. And after that, you cure it. So you have 1/6. Then you have transsphincteric, and transsphincteric, as you know, fistulotomy and fistulectomy. Fistulotomy is actually better than fistulectomy. The healing rates are better, faster, less incontinence. And then you have these ones, which are still low because it's not going up, but there's the extension to the levator. And these are the ones which we are worried about. The internal opening is at dentate line. It's going to between the superficial and the deep external anal sphincter. Then it follows the levator, and then it comes down. So what you can do is you can start your dissection here from inside, cut down till this much. And from here, you go core it out till here. You can core through this, or you can cure it through this, and you can close the external anal sphincter, and you can close from inside. And then you have the suprasphincteric, the same thing you do in this, and you have external levator. So now you have this whole fistula location radially. If it's anterior, you do a fistulotomy, lift or laser here, or you can do a fistulotomy of fixation if it's very close, if it's at distance. Then posteriorly, you can do fistulectomy with primary sphincter repair, lift and cutting. And here on fistulotomy and laser, fistulectomy, lift and laser, and waft. Now, you have to, before you embark on any procedure, you have to rule out systemic disease, tuberculosis, malignancy, comorbidities, and local diseases of the skin. You need to really look it out. And tuberculosis in India, we always keep on our mind. These are all patients of tuberculosis, and they too come up with really bad. You have to have a high index of suspicion. The fistulas are multiple, blue margins, serious discharge, and they're recurrent. So secondary problems you have to see, secondary fistulas, again, tuberculosis, HIV, and is it because this third picture, this is the patient had a laser hematoplasty, and then he had a fistula after that. So fistulotomy, we all know how to do a fistulotomy. There's nothing new. The only thing I can say is you need to repair the anal verge. That means after you have done the fistulotomy, you repair it, and then you muscularize it. The reason why I'm saying is, so the fecal matter doesn't come into the wound. Once you repaired it, all the fecal matter goes down, the wound stays relatively clean. And after you have done this cleaning, you have done the cutting, this is doing the primary anal verge repair. It's very good, and it keeps the anus seepage proof. And that seepage proof actually helps the patient in the long run. And
Dr.
after you
Kushal,
muscularize it.
Dr. Kushal, can you be a little fast to finish?
Yes.
Thank
Then
you.
we have the
Thank you.
primary sphincter repair. These are big repairs. I'm not going to talk about it, but I can show you a picture. This is I've broken down, and you see you have the opening here, and then you have the final result here. That's what we need to do. In a complex fistula, remove all septic foci, save the sphincter, don't divide, not dividing, so core or ablate. Primary sphincter repair, do not damage the puborectalis. Keep your finger, whenever dissecting, keep your finger inside to follow it up. Incontinence, see the high rate of incontinence, and we actually say, nothing happens, and these things can happen. And because of this, what you should learn is from St. Mark's Hospital, Professor Parks said, give an oval incision inside the internal opening, cut it out, and cut up to the intersphincteric space. And you are going to be successful. This is what is being done. And then coring from outside, and then curating inside, the same thing. And then you can tie the stitch, same thing here. When you have an abscess inside, you need to take the whole thing out. You should learn the art of operating from inside. Opening up posteriorly, you need to know how to go between the external sphincter and the internal sphincter. This is the external sphincter here, and the internal sphincter, and this is the tract going between it. Dissect that. And remember, tell your gynecologist friend, do not drain bathroom and abscess. If they have to drain, put in half a cc of hydrogen peroxide. If it comes in the anal canal, to send the patient to you. The other options we have is ceton. You know how to do a ceton. So the chemical ceton in India is causing a lot of problems because it causes a lot of pain and a lot of recurrence with a lot of fibrosis. So you have the sphincter saving procedures, and the results 76%. Lift is laser, and laser is 64%. And lift, simply you just go and you just cut on both sides, and you identify incise, again ligate, and curate. Now, modifications lift is, see all the techniques which have come in with the lift, biolift, lift plug, lift coring, lift waft, lift side to side. That's the latest one which has come in. And you can do any procedures with the lift, and then you have waft. The scope can go in any of the openings, wherever the openings are, and diagnostic on the left side and treatment at this fulguration you can do with cautery, you can do with laser through the through the scope, and you have to close the internal opening and you have to enlarge the external opening. Internal opening is closed by this fish eye technique, and these are two procedures I'm showing you. Just they're very brief films, and what they show is a scrotal fistula on left side, multiple openings on the right side. And if you do it with the scope, you will see that the results are very good. And you close the internal opening in both of them. And on the left side, you see the final healing. This is methylene blue after that. And then you put, you do at the end of surgery. Then at the end of 4th post-op day, end of 30 days. And the healing is quite good. And healing at 5 months. And this was operated by orthopedic surgeon and long track, very good by waft. It goes straight down. The perfect balance can be achieved by hybrid procedures, that is involving waft, lift, and laser together. And when you do this, you have a high percentage of healing and combination of 2 or more procedures. For instance, you in all these procedures, you need to know how to take out the internal opening. Pass maneuver for taking out the coring out the internal opening and removing the central disease is what we want. What you see, the cylinder is removing the external disease. Everything else is simple after that. So I'm skipping these because sir has said my time. Yes, it is definitely up. Hybrid procedures. You can combine all these procedures. They may look very cumbersome. They aren't. When you're doing it, when you want all the gadgets, it's very simple. And see the gratification on the patient. Patient is absolutely happy. I mean, you hardly have any incision. So ablation of the Phylec is what is selling laser machines all over the world. And I'm dead against Phylec because it doesn't work. That is putting a laser inside after curating it from the internal opening, external opening, and thinking that you have ablated the tract and the tract is going to somehow with laser energy stick to each other, and closing the internal opening does not work. It does not work. It fails. We've tried it. We've done everything. You want to do fistula with a laser, you do use bare fiber and do it like you were using a cautery. The advantage is the bare fiber has minimal lateral burn of 1 millimeter. The cautery has a lateral burn of 2 to 3 millimeters. That's the advantage you can get. Despite this procedure being done with perfection, the patient had a recurrence. It doesn't work. So please give up Phylec. Don't do it. If you must do it, you try doing the procedure you would do otherwise. So this is big chapters we can't go. Post-op wound care is a must. You have to do it yourself. Do not use tapes. Kegel exercise after 3 weeks. And take-home message: know the anatomy of the anal canal, anal spaces. Learn to manage the anal glands and tracts. Paradigm shift from anal abscess management. Fistula approach from internal opening. You will get better results. Sphincter cutting surgery with primary sphincter repair. Learn sphincter saving surgery. Do post-op fistula wound management yourself. And these are the 2 books which were released last week, and I'm a co-author. I'm very happy. Atlas Operative Proctology and Atlas Anatomy of the Anal Canal. Thank you, sir. Thank you for giving me time to speak. I'll stop sharing.
Thank you, Dr. Kushal Mittal, for that wonderful exposition. We'll take up the questions together at the later stage. I have immense pleasure in introducing Professor Graham McKay, consultant colorectal surgeon at Glasgow Royal Infirmary. He is a clinical professor at the University of Glasgow, trained predominantly in the Western Scotland with fellowships at various intervals in world-renowned colorectal centers like Leahy's Clinic, Boston, the Cleveland Clinic, Ohio, the GC Medical Center, University Hospital of Japan. His interests today are robotic colorectal surgery, surgical education, and research. He has keen interest in photography. In his non-clinical time, he spends his time as a professional, sort of a professional photographer. Professor McKay served as the Director of Education for the Royal College of Physicians and Surgeons in Glasgow and is a fellow of the Faculty of Surgical Trainers in Edinburgh. So I would play his video in his absence. He will join us for the question and answer session. Is it visible?
Is visible, but no sound yet.
Is it audible?
No, sir. Not audible. No sound.
The sound is quite. Avneet? That's the maximum sound I can get.
But we are not hearing. Okay.
Is it audible?
No, sir. It's not audible. Can you hear it? Can you hear at your end?
I can hear Dr. Mittal, but Dr. Sanjay, can you hear it?
No, Santosh sir, I cannot hear it.
Let us try whether it's audible in the YouTube. Is it audible in the YouTube, Mr. Avneet? Avneet? Is it audible?
No, sir. It's not audible. Can you hear it? Can you hear at your end?
I can hear Dr. Mittal, so I would request. Sanjay, can you hear it?
No, Santosh sir, I cannot hear it.
Let us try.
Sir, you can, Dr. Mike, Professor Mike, you can call him. And if he's on his way, we can take question answer from me while he's connecting.
Good idea. I'll just call him now. Hang on a second.
I think it's a good idea to finish the question answers. Yeah, wonderful exposition once again. Let me put it, Dr. Kushal. There was a question from Dr. Rajiv Sahai. The drainage from inside in abscesses medial to the external anal sphincter, is it done correctly or is it from outside?
From inside. Always done
From
from
inside.
inside. The aim
Okay.
is, since the external anal sphincter is not involved, you shouldn't be cutting it. So you should just cut the internal anal sphincter and drain the abscess instead of touching the external anal sphincter from inside. And the extension should be beyond the anal verge, because post-op you have a problem in dressing. So if it's like 1 centimeter beyond, you can always irrigate and clean it.
Okay.
Santosh, Graham Mackay is going to be able to join us in just a moment. Might be a useful idea if there were any questions for Dr. Mittal, that we can take those. But Graham is just going to log on right now and join us.
We'll finish his questions first. Dr. Mittal, what is the material that you use for CTON?
Actually, it should be a monofilament. It really doesn't matter. It should not be a multifilament. So you can use nylon, you can use proline, you can use infant feeding tube, you can use a rubber glove. The last part of the rubber glove, that strip, you can use that. So any of them can be used.
What's your objection against? What's your objection against it being a braided material?
Braided material, just because we already are in an infectious area, and the braided material cannot be really clean. You will see fecal matter or pus sticking to it every time the patient comes. But if it's a monofilament, you will always see it shining. Nothing is ever stuck on it. Even on the glove, you get sticking, but for ethylene and proline, they're absolutely clean. Now, I skipped that part because CTON is of two types. One is draining CTON, when you have an abscess and you want to drain it, your biding time, you want a fissure to develop, too much muscle is involved. And then you can change that and make it a cutting. Now, the principle of cutting CTON is it's got to be around the external anal sphincter only. No mucosa, no internal anal sphincter, no subcutaneous tissue, and no skin. So you have to bare the external anal sphincter from both the sides and then take the thread around it, and then you can cut it. So you can cut it in one go, like tighten it very tight, or you can take 3 or 4 threads and tighten one of them, keep 3 loose, and every week you cut the first one out and tighten the next one. Or you can have a rubber glove. Every week you pull it down and then you tie a linen thread there so that it becomes tighter. So various ways of doing it.
How often you tighten it?
Once 7 to 10 days. In that time, the previous one has become loose. So you take that out and you put this new one.
Okay. The other question that is there, if you have got 2 abscesses on one side each, and they are not connected, whether you would do 2 sutons at the same time?
First of all, you should be very clear that they are actually not connected. So you need a MRI proof that they're not connected, because 2 abscesses from 2 different internal anal glands and internal opening, if they are there, you use 2 CTONs. But you have to really rule it out. It's very rare to have 2 abscesses and without communication. But if they're not, you put different CTONs in there.
The other question that has come in.
Sorry,
I'll just finish
with us now.
Yeah, just one more question. Can't we give? Question is, let me just see. Can't we give an incision at the intersphincteric groove and cure it and ignore the internal opening if it is a low opening?
Actually, I don't really have it understood. What he's saying is basically a fistulotomy. That is, from the intersphincteric groove, you're going up to the internal opening. And if you're cleaning it out, just cleaning it out is not going to help. You need to cut that whole thing out. So it becomes a fistulotomy and muscular.
Yeah, I think, I'll take up the questions later. Since Professor Graham Mackay has come in, I would request him to share his slides. And unfortunately, the voiceover was a little too weak and we couldn't hear you, sir. So over to you, Mr. Professor Graham Mackay. Welcome to this webinar. And on behalf of both Royal College of Physicians and Surgeons of Glasgow, and on behalf of ASI, let me extend a warm welcome to you to this gathering. Professor Graham Mackay, please.
Thank you. Let me see if I can share my presentation, and if the audio works for me, we'll continue with that. If not, I'll just talk to the slides.
Yeah, it started coming in.
A consultant colorectal surgeon at Glasgow Royal Infirmary. Can you hear that?
Yeah.
And
Yeah.
I'm talking to you as part of this webinar series in conjunction with the Royal College of Surgeons in Glasgow and the Association of Surgeons of India. The main part of my work is as a robotic rectal cancer surgeon, but I also have a tertiary referral practice for benign proctology conditions. And I've been asked to talk to you today about perianal sepsis and anal fistulas. Now, one of the things that I like to do if I can is to keep things as simple as possible, particularly when it comes to working up and treating patients. I'm sure you all know there are tens or even hundreds of different procedures described for treating anal fistulas. So which ones do we need to know about, and which are likely to give the best outcomes for our patients? Well, today I'll give you my opinion based heavily on what evidence there is available and guided by my experience with some of these techniques. So the majority of anal fistulas are as a consequence of cryptoglandular sepsis, and that accounts for around 80 to 90% of cases. But there are a range of other conditions which come into the differential diagnosis and which should be borne in mind when assessing patients. The most common of these in my practice would be Crohn's disease, but there are a number of other conditions, including malignancies, diverticular disease, TB, and HIV, for instance. And the incidence of some of these will vary depending on your geographical location. There was a nice study from St. Mark's Hospital in London a few years ago now, where they analysed the outcomes of 2,000 patients presenting with acute anorectal abscesses, and they found that between 15 to 20% of patients went on to develop an anal fistula, and this rate has been confirmed in other studies. One of the common questions relating to the index presentation with an acute abscess is, should you look for or treat a fistula at time of the initial drainage? Given that the incision and drainage is often performed by more junior members of the surgical team, I don't advise that you go looking for a fistula, as this may simply complicate the initial presentation. Of course, if there is an obvious fistula, then it is reasonable to place a loose draining seat and suture if you have the skills to do that safely. I would also avoid packing in the post-operative period, as we know this just increases pain, and there is some suggestion it may increase the fistula rate, although this is by no means certain. I would just encourage you to make the initial incision wide enough to allow adequate drainage. How then do we assess an anal fistula? Well, the first and most important thing in assessing any benign proctology condition is to listen to the symptoms. This will give you an excellent idea of what the likely diagnosis is, but it will also tell you what the patient's priorities are for their management. And this should be a prime focus of how you then go on to treat the patient. Following a detailed history comes a thorough examination and documentation of the findings. In my opinion, I learned so much more from clinical examination in fistula disease than I do from any kind of imaging. Imaging may confirm or modify the findings of my examination, but it's certainly no replacement. Imaging is, of course, very useful for accurately classifying the fistula, and we'll come on to that in some later slides. Remember also that examination in anal fistula is about examination predominantly of the anal canal, and so most of that is achieved with the tip of your finger from the DIP joint onwards. You want to document the external opening and its distance from the anal verge, then the internal opening, which you can feel like a little grain of rice in the anal canal, or if necessary, by injecting through the external opening. Now, from that, you can either predict or feel the course of the tract by pinching between the index finger and thumb and using Goodsall's rule, which I'll show in a wee minute. You also want to have a feel for any fluctuance in the ischiorectal fossa to suggest associated collections or induration from secondary tracts. Examination might also allow you to pick up characteristic features of other complicating conditions. This then is Goodsall's rule, which helps you to predict the possible anal fistula tract and its course between the external and internal openings. And it shows that for anterior fistulas, they tend to have a direct tract, and so the external opening will probably correspond to a similar position with the internal opening. And for posterior fistulas, these tend to track to an internal opening at the 6 o'clock position. And while this is not exact in all cases, it's certainly a useful guide. Cryptoglandular fistulas originate from an anal crypt gland, which are arranged circumferentially around the anal canal at the level of the dentate line and penetrating through the internal sphincter, ending in the intersphincteric space. These tend to result in intersphincteric, transsphincteric, or suprasphincteric fistulas, while extrasphincteric fistulas are more commonly due to an alternate pathology, such as Crohn's or diverticular disease. This is known as Park's classification and is probably the most commonly used for describing anal fistulas. The only thing we might add, which was not included in Park's classification, is the superficial or submucosal fistula, which does not involve the anal sphincter and is generally much easier to treat. An additional method for classifying anal fistulas is in relation to their complexity. So a simple anal fistula is one that's either superficial, intersphincteric, or low transsphincteric, and that's involving less than 30% of the external anal sphincter, or complex perianal fistulas. And these are ones with multiple external openings, horseshoe tracts, suprasphincteric or extrasphincteric fistulas, where the external opening is more than 2 centimeters from the anal verge, where the tract involves more than 30% of the external sphincter, and that is a high transsphincteric fistula, or fistulas which are recurrent or related to IBD, malignancy, or radiation, or where there is pre-existing incontinence. After taking a thorough history and examination, the next step for most patients considering surgical management is to perform an examination under anaesthetic. Imaging is performed for patients with complex fistulas. Patients with simple fistulas do not require imaging and will go directly for surgical management. When it comes to imaging, this is either by an endoanal ultrasound or MRI, depending on local availability. They have very similar sensitivity and specificity, although ultrasound is a little more operator dependent, and in my practice, we use MRI pretty much exclusively. For patients at risk of or with a pre-existing history of incontinence, I may also arrange anorectal physiology to get an assessment of sphincter's function. The aim of treatment then is to relieve symptoms while maintaining sphincter function and continence. And to do that, we need to define the fistula anatomy, as we have just described, drain any sepsis, and then eradicate the fistula tract. And that's where we come on to considering the definitive procedures to try and close the fistula. For simple anal fistulas, the goal is to perform a fistulotomy, a relatively straightforward procedure with high complete healing rates. This is performed by simply opening onto the fistula probe, and then I would combine this with marsupializing the edges of the wound. This reduces the size of the wound, and there's good evidence that it significantly reduces healing time. Fistulectomy has also been described, often involving coring out the fistula tract, but this should be avoided as it leads to longer healing times and carries a higher rate of fecal incontinence. For more complex fistulas, I would always follow a staged approach to closure, with the first step being to place a loose draining seton suture for a minimum of 6 weeks. Often there can be confusion around the principles of seton sutures. The main purpose of a seat and suture is to provide unobstructed drainage, as this will minimize symptoms and makes further abscess formation unlikely, although not impossible. I'll also use a seton in combination with simplifying the fistula by laying open the external portion of the tract and any accessory tracts or collections, with the aim of leaving a shorter single tract in the sphincteric portion. Cutting setons have also been used to slowly cheese wire through the fibers of the anal sphincter. I have to say that I don't use cutting setons now, as they can be intensely uncomfortable for patients, and incontinence rates are not insignificant. I think most units have now moved away from employing these commonly. And of course, for some patients, a long-term seton is a perfectly viable option. It's the only option for complex fistulas that does not carry the risk of deterioration in continence. So for patients who don't wish any additional risk and may have minimal symptoms, it's a reasonable option. Issues to consider for this is the type of material. Usually use soft rubber for a long-term seton, and try to fashion a low-profile seton. Patients have to live with these, and I see some coming with long dangling setons with multiple knots made in the rubber, which are just bulky and not comfortable. Once the patient has had drainage for at least 6 weeks, then attention turns to a definitive procedure to try to heal the fistula through a sphincter sparing procedure. These can be categorized into filler procedures, using a variety of materials from collagen paste and plugs to stem cells. Ablative procedures, the Filac procedure using a laser to ablate the tracts, and the VAF procedure, which usually uses diathermy ablation assisted by curettage under endoscopic guidance. And closure procedures, with the main ones being advancement flaps or the lift procedure, which stands for ligation of intersphincteric fistula tract. In general terms, evidence would suggest that technology-assisted procedures have lower healing rates than technology-free procedures. So for once, there's something to cheer up the finance director in your hospital. Minimally invasive procedures also have documented rates of incontinence, so don't let someone tell you that they can treat complex fistulas with no risk of incontinence. As we said before, simple fistulas are best treated by fistulotomy, and healing rates of anything close to 95% have been described for this procedure. For fillers, healing rates are somewhere between 30 to 50% in the literature, and I would suggest that true healing rates are towards the lower end of that scale. Recurrence is high, and in my practice, I simply don't use these. In a national health system like the one I work in, these procedures don't offer a cost-effective solution. Of course, in a private system where cost is less of an issue, then the balance of risk and benefit may change. More recently, there's been a lot of interest in ablative techniques, the Filac and VAF procedures. If I had money for every time one of my trainees tells me how great the VAF procedure is and that I should really be offering it, well, I might be able to afford some of the equipment to carry out the procedure. As with a lot of new procedures, the evidence is now starting to temper some of the initial hype. Studies suggesting healing rates between 60 to 90% were seen at the start when this was described, but a more recent Italian study in the Colorectal Disease Journal showed a recurrence rate of 30% at 1 year, rising to over 60% at 5 years. Now, these results are not much higher than simple curettage alone. We know from the recent ADMIRE study analysing the use of adipose-derived stem cells in Crohn's fistulas that around 40% of fistulas in the control group closed from simple curettage alone. Then you have the closure techniques of advancement flap and lift procedure, and it may not surprise you to hear that these are by some distance my favoured techniques. They have both robust, longer-term evidence with higher healing rates than other procedures and relatively low rates of incontinence. The largest long-term series of the lift procedure was published in the Colorectal Disease Journal in January 2019. This showed that in 70 patients with at least 16-month median follow-up, healing rates of 80% were achieved. A recent meta-analysis of 52 randomized controlled trials analyzing fistula surgery showed no evidence of superiority for any single fistula treatment in terms of healing rates, but the lift procedure was found to be associated with less bowel incontinence. If we turn our attention then to Crohn's fistulas, which would be the other main etiology that I would treat, their management is somewhat different to cryptoglandular fistulas. Treatment here involves initial drainage of sepsis, and then, as before, I would place a loose seton as a first stage of management. Unfortunately, recurrent sepsis can still be an issue in up to 40% of patients with Crohn's with a seton in place, which is much higher than in the cryptoglandular group. Then medical management is an option for patients with Crohn's, and these take a variety of different forms. Antibiotics such as metronidazole or ciprofloxacin can improve symptoms of pain and discharge in up to 90% of Crohn's patients, but they don't heal fistulas. Thiopurines such as azathioprine have limited efficacy as monotherapy, but can be used to increase effectiveness of biologic agents. Then we have some of the biologics, and there's good evidence to support infliximab, adalimumab, and vedolizumab for treatment of Crohn's-related anal fistulas, with healing in around 30% of patients. One of the issues that then arises is when do you remove the seton to allow complete healing? And there's no absolute consensus on this. Some remove it after 6 to 12 weeks from the start of treatment, others remove it based on reduction of discharge. Some of the newer biologic agents have insufficient evidence to be used for anal fistulas currently outside of a trial setting. In terms of surgery, I'd be much more cautious about performing fistulotomy in Crohn's patients who are at much higher risk of incontinence for a variety of reasons. For a definitive procedure to close the fistula, I would only consider this if and when luminal disease remission has been achieved, and healing rates are much poorer as a rule in Crohn's patients. At the more simple end of the scale, I would employ either the lift procedure or anal advancement flaps. For rectovaginal fistulas, you may need to consider an operation where an interposition graft is placed between the rectum and vagina, such as a gracilis flap. And in fact, we did exactly that procedure just last week for one of our Crohn's patients. Of course, in very complex fistulas or where there is uncontrolled sepsis, then you may need to consider a defunctioning stoma, plus or minus a proctectomy, which can be combined with a flap reconstruction to get adequate healing of the perineal wound. So to summarize my normal approach to anal fistula management, I would usually start with an examination, either in the clinic or under anesthetic. For simple fistulas, I do a fistulotomy, and in the majority that will be enough. For complex fistulas, I would use a staged approach, starting with seton drainage and simplification of the tract if possible. I would usually get an MRI to help define and fully classify the fistula, and the procedure I use most commonly for closure would be a lift procedure, but I would also occasionally use advancement flaps. Now I'll explain in just a little more detail how I go about performing the lift procedure. I should say that these are not my photos, but they do show quite nicely some of the steps of the procedure. So firstly, the fistula is defined. Here that is being done by injecting fluid through the external opening, and we can see the internal opening at the 12 o'clock position. So not exactly following Goodsall's rule here. Usually I would have a seton already in place, so defining the fistula has already been done. We then make a curved incision in the intersphincteric groove, which can be identified by putting the sphincter on a stretch with a retractor. Once we're in this plane, it should be relatively bloodless, and it can be developed down to the level of the fistula tract. Once we get down to the level of the fistula, we encircle it, usually with a right-angled forceps, as you can see here. At this point, the fistula can either be ligated in continuity, or what I would do more commonly is to divide the fistula tract and suture ligate either side as it passes through the intersphincteric space. I would then curette the external portion of the tract. This gives you an opportunity to see if your suture closure of the external side is secure. In this photo, that suture ligation has obviously not yet been performed. I would then also core out the external opening at the skin to ensure good external drainage. Again, I don't use packing, but advise the patient to take regular baths and use a sanitary pad in their underwear. And I would see closure usually between 6 to 12 weeks. And in my own series, healing of about 75 to 80% is my own experience in well-selected patients. This final slide shows the operator now suture ligating the divided fistula tract on the external anal sphincter side. To finish then, I'll show you a small audit of my practice, which I carried out a few years ago when introducing the lift procedure. I carried out 115 procedures in 54 patients over a 5-year period. And you can see the ratio of male to female patients, with the median age of patients with Crohn's-related fistulas being considerably younger than those with cryptoglandular fistulas. And this is in line with what we might expect. Of the 43 patients with cryptoglandular fistulas, 38 patients had closure of their fistula at the time of the audit, with the median time to closure being 6 months. 2 patients opted for long-term setons, and 2 patients defaulted from follow-up, and so further data on their outcome was not possible. And 1 patient with complex perianal sepsis was awaiting a further definitive procedure for their fistula. Of the 38 patients who had closure of their fistula, 9 were closed at the index procedure by fistulotomy. 20 were closed at the second procedure after a period of seton drainage. 13 of these were then suitable for a fistulotomy, and 7 patients went on to have lift procedures. 9 patients required 3 or more procedures to close their fistula, and these included fistulotomies, lift procedures, and an advancement flap. Of the 11 patients with Crohn's-related fistulas, 6 patients have had closure of their fistula. These required more complex surgical procedures, including a lift procedure, defunctioning stomas, and gracilis interposition grafts. 5 patients have ongoing fistulas, 4 with long-term seton drains in place, and 1 with a defunctioning stoma with good symptomatic improvement. And so you can see that the outcomes for definitive closure in Crohn's-related fistulas is significantly lower than that in the cryptoglandular group. Of the 12 patients who had lift procedures, 10 had successful fistula closure, giving a healing rate of 83%. And 1 of these was in a Crohn's-related fistula. Of the 2 patients where the lift procedure failed, 1 patient required a further advancement flap, and 1 patient required a further fistulotomy. 1 patient in this group did report worse fecal soiling following their lift procedure, showing that no procedure is without the potential for complication. Although anorectal physiology and endoanal ultrasound in this patient were normal, and the patient did report symptoms of incontinence predating their lift procedure. So I hope you find that useful in helping to structure your understanding of the management options in perianal sepsis and anal fistula. It just remains for me to thank RCPSG and the ASI once again for giving me the opportunity to speak to you. And I hope you'll allow me just to give a little promotion to the Scottish Tourist Board. As well as being a surgeon, I'm also a keen photographer. and we are spoilt in Scotland with some truly amazing landscapes. So if you do get the chance to visit at some point, I'm sure you'd be given a very warm welcome.
Thank you, Professor Graham McKay. Equally interesting your photographs as your surgeries are. So congratulations and thank you very much from all of us here gathered on the brilliant exposition of the topic and the photography, needless to say.
Thank you.
I have few questions which is left for both of you. I'll start with Professor John McCain. What is the ideal material that is used for seatoning in Crohn's disease?
I think in Crohn's disease, I would normally be using a rubber material for the seton, in that it's usually just to provide drainage rather than anything else. And so you're looking for something that's soft and comfortable and that the patient can live with for possibly a significant length of time. So usually I would be using a rubber seton. That would be a fairly snug loop tied with some silk sutures to try and make a very low profile suture. You don't want it long or with several knots in it. So something that's secure and going to stay in, but soft and comfortable so that the patient can live with it.
You mean to say that you use it more as a draining seton than a cutting seton?
Yeah, very much. I don't use cutting setons, particularly in Crohn's patients, but not really in any of my fistula work. Now, we used to use them in the past, but don't tend to use them now.
What about monofilament material? You still prefer rubber gloves? Rubber material?
Yeah, we do just for the comfort. I think that the using monofilament sutures the ends of these can tend to dig into the patient's skin and cause irritation, and so we tend to use just a loose rubber sloop.
Okay. Is the rubber material just like the vascular slings that you are using, or is it something else that you are
Exactly.
using?
Exactly. There are more expensive designed setons these days where one end of the rubber tube can be placed inside the other so that it forms a perfect ring. But in a national health system, when you can use a very cheap rubber vascular sloop, then we just tend to use a vascular sloop. Yeah.
I'll ask this question to both the faculty. How do you tackle multiple fistulas with a single external opening? I would request Professor Graham to take the first chance, and then we'll come back.
Yeah.
Multiple tracks with a single external opening.
I think that would in fact be very unusual. What you much more commonly see is multiple external openings with draining to a single internal opening. And so in that kind of fistula, that's obviously a complex fistula. So we would aim to make a roadmap of that fistula first, as Dr. Mittal was describing, to try and design the management for that patient. But often what you'll find is that although there might be multiple external openings, these drain going through the intersphincteric space as a single opening in the anal canal. So often, in fact, for those procedures, a lift procedure, tying off the single tract that passes through the intersphincteric space will treat those fistulas. Often a lot of the branching of the fistula will be external to the sphincter complex.
In the Indian context, is this the same as you see Dr. Kushal?
Single opening and a complex fistula with probably would have one single internal opening also. And what we would do is we would cut out the internal opening, that is, core it out, the internal opening up to the intersphincteric space. And then you start cutting, put in methylene blue with little hydrogen peroxide, you start cutting outside like coring, and you start following it up. And when you do make a racket-like incision, just make a circular incision, and towards where the fistula branch is going towards the anus, make about a centimeter incision. So you have a very small incision, and you follow the fistula. Follow the fistula wherever it goes. Now, what you need to understand is in a complex multi-tract external opening one, it will be impossible to pass a seton also, because your probe is not going to go into the tract, it's not going to go to the anal canal. If you take out the internal opening, it is like, you have your in the sand dunes, and you have a logs of fire, and you have fire on top. And if you take away the logs, the fire will die out. So if you manage the central disease, that is the internal opening, internal anal sphincter, the anal gland, if you take the whole thing out, then you've taken out the source. Now what is left is the after effect, and that you have to just follow the tract or curate the tract, or if possible, put in a drain in that tract. But try to know the tract by MRI beforehand.
Yeah, there is a question on MRI. As the investigative modalities are finding its development, moving from ultrasound to CT to MRI to whatnot, every disease has got an indication to get into any of these investigations, starting from breast to thyroid, anything. You can have any of these investigations done. And is MRI an investigation which confuses most, than often it helps the surgeon to plan the disease, plan the treatment?
Can I answer that?
Yeah, it's open to both.
The MRI is a beautiful investigation. The radiologist has to be good. The radiologist needs to know how to make a diagram. The surgeon is not concerned with the film. The surgeon doesn't have time to go to the console and see the whole tract, unless it's in his own hospital. Even then, he may not have time. But if the radiologist is good and he marks it, like I showed you the diagram, if he marks it, believe me, on table, you will find the same finding. But if you're looking at a film and you're reading a report, which is like 2 pages of a report, you're never going to find what's going on. So the first thing you have to do, and what we are endeavoring on 3rd December in Pune, is train the radiologist. The radiologist and the surgeon have to be in sync. And we are very poor in not giving enough information to the radiologist. We just write MRI pelvis, which is wrong. It's got to be an MRI perineum or MRI fistography. That is going to give you a good roadmap. And don't look at the films. The films, because the fistula is going up or down or across. And in one film, you only get one part of the fistula. So it's not possible. But if he draws the diagram and if he makes a glamour film, you can understand it.
Your thoughts?
Yeah, no, I very similar. I would agree with that. The MRI is very useful to make a roadmap. One of my colleagues does use endoanal ultrasound, but it's highly interoperator. There's quite a lot of interoperator variability. So if you have the skills, then endoanal ultrasound is useful. But we tend to use MRI, and I think, as has been explained, the films are maybe not as useful to me as sitting down with the radiologist and really discussing it, mapping it out, so that you have a very clear, a clear roadmap in your mind as to what the scans are telling you. They're quite difficult to interpret, and so that needs to be a combined approach of radiologist and surgeon together.
Continuing on the same topic, would the 3-dimensional reconstruction be of use in a complex fistula program?
Yeah, it's certainly in use in some centres. I know colleagues in St Mark's have done some work on 3D reconstructions. I think the difficulty at the moment is with 3D reconstructions, most of these they're quite time consuming to produce. They are usually being done currently by external companies, so they're expensive to have these produced. And I think the current evidence, it's not entirely clear whether these significantly improve management. So at the moment, we don't use 3D reconstructions. We don't feel that it's currently that the cost is justified. But I think we may well see 3D as these become more available and easier to get, then they may well become part of our management in the future.
There is an odd question which the context I'm not 100% able to conceive myself. But then the question is the role of primary reconstruction of sphincter after a hysterectomy. I suppose the question I would reframe that if the patient has been rendered incontinent, probably what is the role for sphincter reconstruction? Something of that probably.
No. That's not. The question is okay.
Okay,
when
fine.
you are doing a fistulotomy and when you're doing a fistulectomy, the muscles you are cutting are in the internal anal sphincter and the external anal sphincter. Once you have tackled the fistula, that means in fistulotomy, you will curate it out. In fistulectomy, you will cut around the fistula and take it out. The muscles are left open. Now, if you don't stitch them back together, like if you have done a laparotomy, you don't stitch the muscles back together, then it's going to cause incontinence. So you need to take care of it.
I think the question to me looked as though you're going to recreate the sphincter at a later time. Or,
no.
Often,
later date sphincter repairs are very bad. They have very bad 5-year progressive rates.
Yeah. That's what I thought the question was aiming at. Maybe my comprehension was bad, but that's what I thought the intention was.
I would agree with you. Initially, there are primary procedures that would involve dividing the sphincter, and primary reconstruction is essential in those. I have to say that we tend to avoid those and go for more sphincter saving procedures when we can. And absolutely agree with Dr. Mittal that secondary repair of the anal sphincter, the outcomes are very poor, and so we would be looking at.
I thought, I had a distinction between a primary repair and the reconstruction. That's all. The primary repair, yes, I wouldn't have had second thoughts about that. When it came to reconstruction,
I think the wording was different. That's all.
Yeah. I thought that's the reason why I have. I was a little confused about the whole thing. Repair, I don't think there is a question or a confusion. When it refers to reconstruction, you're trying to, bring in tissues from somewhere, like some flaps or something of that kind. Anyway, the other question is the role of colostomy in Crohn's fistula healing. I suppose Professor Graham can take on that.
Yeah, I think that for very complex, when you have complex fistulas, particularly in patients with Crohn's where the luminal disease is not controlled, then a defunctioning stoma is a reasonable option for those. Really definitive management of fistulas in Crohn's can only be considered if particularly rectal luminal disease is under control and quiescent. So, for instance, the patient that we just did, we make sure that she has good control of her rectal Crohn's for at least 3 to 6 months before we would then consider a primary procedure. And in that case, it was a rectovaginal fistula. So we carried out a rectovaginal fistula repair with, in fact, we had planned for a grassless flap, but instead we used a gluteal fold flap, taking an adipose flap and putting it into the space between the rectum and vagina. So defunctioning stoma, yeah, absolutely can be used in uncontrolled sepsis and particularly in active Crohn's disease, and that can give good symptomatic management. But unfortunately, it's not a panacea in that patients with bad perianal Crohn's disease, even after defunctioning, up to 40 to 50% of them can still have pretty bad symptomatic perianal Crohn's disease, and those patients would generally tend to go on to be considered for proctectomy. In terms of, I guess, the other question that sometimes people will have is about defunctioning stomas as a combined to defunction the rectum prior to doing a definitive procedure, either in Crohn's or without Crohn's. And we would tend to, I would tend to avoid that. I think there's not great evidence that a defunctioning stoma is required just to divert the fecal stream so that a fistula repair will work. And so we tend to avoid defunctioning stomas just to protect a definitive fistula repair.
Thank you. Thank you very much for those answers. In the context of Indian context, how often, Dr. Kushal, would you have confronted tuberculous pathology in fistulas?
That's a very nice question. You would be surprised. I have not seen a single case of Crohn's, but tuberculosis, I would say about 3 or 4 patients a year. And how do we detect them? They're usually multiple openings and usually blue tinged. Usually patients have mild fever going on, they're losing weight, they're not eating. And you could tell by the look that is tubercular. And what we need to do for tuberculosis is you take a biopsy of that external opening, send in the pus for TB PCR, send the tissue for TB PCR, and send it for histopathology. When you get a positive report, then you start your anti-tubercular drugs, 4 drugs for 2 months and 2 drugs for 4 months. In this time, if there is no abscess, it's better to wait and watch. You would be surprised to know that most of the fistulas will heal. Any fistula, surface mantle fistula, any fistula which is not healed at the end of 6 months, that fistula you can go in for surgery and take that fistula out and send it again for biopsy. Again, TB PCR and histopathology. But it's what is going wrong? When the normal fistula wound, multiple fistula wound is not healing, the surgeon feels that it's tuberculosis and they start at random anti-tubercular drugs, which is wrong. Unless you have a histopathological proof, you can't start taking.
Yeah, I would go one step ahead. The histopathology is probably only corroborative evidence. One should demonstrate, if possible, mycobacterium or an amplified nucleotides methods to detect it in PCRs.
Yeah.
So just like any other tuberculosis.
So that's why TB PCRs are more sensitive.
Yeah, TB PCR or anything of that sort. So these are the questions that have come up, and we have almost an hour and 45 minutes from the start of a very interesting and a very common, more distressing, perianal pathology, which have a go, at least in our part of the country, our part of the world, by unqualified, untrained people also, because people are really ashamed to go to modern medical care and get, ideal treatment. So if any of the panelists here have got anything to contribute, please contribute. And I'll take the questions if there are any more coming in at the last part. Professor Makadi, Mike Makadi, for your comments.
Well, thank you very much, Dr. Santosh. Just to say what a wonderful first start to the collaboration between ASI and the Royal College here in Glasgow. I think we all know as general surgeons the acute treatment of perianal sepsis is something that we've been dealing with since first year SHOs, often, I suspect, very badly. And I listened with great humility to Professor Mittal and Professor Mackay telling us how we should have been doing it over many years. So that's wonderful to hear and share that expertise this evening. And I think both stress the junior surgeon should at first do no harm, primum non nocere, that old concept in surgery, just to do no harm first of all. And it's wonderful to hear from the experts this afternoon, this evening, what we should be doing in definitive management. So thank you to both of them and to ASI for all of this collaboration around today's webinar.
I'll have a couple of comments from Professor John Scott, if he's there. Okay, Professor John Brennan, if you can make some comments, if you want to, please.
Yes. Thank you, Professor Mackay, Professor Mittal, for the excellent talks that you delivered. Certainly, myself being a colorectal surgeon, I learned a lot this evening, and certainly the principle of first do no harm is very important in management of perianal fistula disease, especially given that many patients present during emergency hours, on-call hours, where only junior surgeons would be available most of the time. So certainly plenty of lessons to learn. And as I said, I've been very pleased with hearing both of your talks. And this is an excellent start to our series of webinars. And may we continue progressing in the same way. Thank you very much.
Thank you, Professor John Brennan, for those wonderful words. I may have President ASI for some comments.
Thank you, Santosh sir. Yeah. What I would like to say here, and a patient with any perianal pathology, at least in this country, walks inside the chamber of a surgeon with lot of pain and lot of apprehension in their mind, and have to knowledge from some of their peers or their relatives. So it is our prime duty to first reassure them, which is very, very important, assess and do as all the experts have told us today. Although this topic is very, very wide, and every case we do not get two similar cases. So I hope the community today who was watching and those who will continue to watch this program will be grossly benefited by this and will love to be the part of our next programs which are coming. Thank you. I will say my sincere thanks to Mike, the two Johns, Graham and Kushal. What a great way to start. And of course, Jen, who took up this program in just at the last moment, is still helpful me in guiding to, and of course, in her absence, I would like to thank Fiona, who basically encouraged me to go with our own platform. And this time they had a good platform, and we are able to make, and we are able to have a very flawless relay on YouTube live on our own YouTube channel of the Association of Surgeons of India. I think this is going to be working in long run. Thank you everyone for making their part of contribution, and then we will be sharing few good moments in future. Thank you.
Thank you very much, Professor Sanjay Jain. There are a couple of questions of which one has already been answered about the single external opening and multiple internal tracts. It has already been answered. One question which probably worth answering is that any dietary changes are required in fistula in
I think diet actually has little to play a part. If it was a fissure or a hemorrhoid, I would say yes. For a fistula, no. But I would just say they should have normal motions, and they need to do whatever they can to get a normal motion, but no dietary restriction.
Okay. One interesting question is, what's your advice on fistula patients against swimming? You know,
Professor,
one of you can take it.
The water has chlorine in it. So whenever I operate patients, they ask me, when can we start swimming? I said 3 weeks after your fistula is healed completely. And if there's any discharge, you can't go. And they won't listen to you, but you just say the chlorine will go inside and make it, how you give you a recurrence. So that deters them from going to the pool. They're going to infect other people. There's no point going in the pool, and they're going to infect themselves.
Thank you. Thank you, Mithil, for those exhibitions. Royal College of Surgeons of Physicians and Surgeons of Glasgow is in the forefront of educational activities. And I'm sure that Jennifer would like to say a few words before she winds it up. Thank you for joining, Jennifer, to this midst of surgeons. You are in charge, or you are somewhere connected to the academic activities of the college. So, in your thoughts about this joint webinar, please unmute. Yeah.
Thank you very much, everyone. Thank you for your time and for the opportunity to share some of the educational content that we are delivering currently. If you just give me a moment, I'm going to share my screen and hopefully be able to show you some of our upcoming education that will be of use to you in your practice. So it's a change of tact. It's non-clinical skills courses to help you become better trainers, better mentors. All of this is online, so you can access it at a time that suits you and suits your development and your educational needs. All interactive with our experienced trainers in college. And I would urge you to go onto our website. I will share these links after the presentation so that you can find out a little bit more. But you'll see there's lots of leadership, mentorship, clinical leadership, everything that we need to support you in your career development. The next one is our inequalities in healthcare. So this is our President's Conference this year. And again, I'm delighted to say it's on the 16th of November. It's online, live. You can engage with all the faculty and delegates online. There'll be an in-person audience in our Glasgow College hosted by Professor Mike McCurdy. And I would again encourage you to go online to have a look on our website to see what there is that can help support you again in your career development. Again, I'm focusing here on our non-clinical skills because that's content that you can access at any point, anywhere. It's not limited to coming to college, although we would be more than happy to welcome you to college if you are here. Final thing to update on is the exam. We're again extremely excited to announce the opening of 2 new centres in India. We will be in Pune in February 2024 with the exam closing date in November. Again, just dates for your diary. Excited to be out and opening new centres with you. Thank you very much.
Thank you, Jennifer, for those informations. I think a very good start for a great combined meeting of both Association of Surgeons of India and the Royal College of Physicians Surgeons of Glasgow. And we plan to have a quarterly event, and I hope this will be a very, very informative session for those who are interested in that particular topic. I think it's time to wind up. We had a very good session. I think there are a couple of questions, but then some of them have already been answered. As customary, I would invite our secretary to say a formal vote of thanks. Sanjay, you wanted to say something?
Yes, just about the topic of the next webinar is going to be the management of rectal prolapse, and where the Vice President of the Royal College himself is going to present from the RCPS side. And this is again something which lot of queries in people's minds. So we have again selected a topic which will be of wide interest to everyone.
Before I formally hand over for the vote of thanks, on behalf of the entire membership of Association of Surgeons of India, on behalf of the President Executive Committee, I would like to extend a warm welcome to Mike McCurdy to attend our national conference at Visakhapatnam in December, and a warm welcome to India and to ASICON well in advance. We'll meet at Visakhapatnam, and now over to Pratap Borde for his concluding remarks.
Thank you very much, sir. Good evening, all the esteemed faculties present here today and the participants on the YouTube from India and abroad. A great beginning of the webinar series, which is a joint venture of Royal College of Physicians and Surgeons of Glasgow and the Association of Surgeons of India which has materialized because of the efforts taken by the principal office bearers from both the associations. On behalf of ASI headquarters, it's my proud privilege to thank our own President ASI, Dr. Sanjay Kumar Jain, President, Royal College of Physicians and Surgeons of Glasgow, Dr. Mike McCarty, Vice President ASI, Dr. Prabol Neogi, Vice Presidents of RCPS, Dr. John Brennan and Dr. John Scott, Director Academic Council ASI, Honorable Dr. Santosh John Abraham, sir, Convener International Affairs, Dr. P. Raghuram, OBE, for his consistent efforts, Director of Education, RCPS Glasgow, Dr. Jennifer Crozier, Registrar, Royal College of Physicians and Surgeons Glasgow, Dr. Abhay Rane, and most importantly, today's esteemed speakers, Dr. Graham Mackay from Glasgow and our Dr. Kushal Mittal from India, and all the participants from all over the globe for participating in large number for this webinar series. A big thank you on behalf of ASI headquarters for joining in today and making this program a very tremendously successful. Well begun is half done. We will be back soon with yet another interesting webinar in near future with yet another interesting topic. Thank you very much, sir.
So thank you all for attending this meeting. Let's say goodbye to each other and good night. Safe.
Santosh sir, it is we should not forget Avini for hardcore effort to make this entire thing possible for us.
Thank you, sir. Thank you.
Thank you.
Thank you.
Everybody.
Nice.
What a wonderful start. Thank you very much indeed, everybody. And have a good evening. Bye-bye now.
Thank you.
Yeah.
Bye-bye.
Stay safe.
Bye-bye.
Good night.